meeting in different language. The other function that we have is questions and answers. This is where you can ask your question for it to be answered by today's participants. We do have time for questions and answers, and if you do want to ask, please ask here. Another function that I'd like to demonstrate is a chat function. Now, this is the function that you do not use for questions and answers. This is where you can introduce yourself. This is where you can tell us where you're from. This is where you can put a thought or a suggestion for our next meeting. But please do not ask questions here because we may miss those questions. We have a lot of participants in today's webinar, and if we miss accidentally your question here, then we may not respond to it, but we can never miss it in Q&As. Let me tell you briefly about some other non-Zoom resources that you can use. I sincerely apologize for today's conflict in Zoom, and this is the best way I can show you my slides. Sincerely apologize, but the information is here, so you can still see. We do have a website. We do have free online trainings. We do have a YouTube page. We do have a Facebook group, and we have a LinkedIn page. And what you do to access all this, you type in your browser IFC IQ Healthcare. And IQ stands for improving quality. So IFC IQ, which is improving quality healthcare. And any browser that you use, it will take you first to our general web page, improving quality in healthcare, and you can find all of our resources there, or all those resources will be listed in your browser. Okay, another useful resource for you are our sister programs. For healthcare, except for healthcare quality advisory program, we do have healthcare benchmarking program, and medical facilities are invited to join it to compare performance with other medical facilities, to understand and come up with performance indicators and targets for your specific medical facility, to help you generate evidence for investors and for presentations to your boards, and to make investment decisions that are evidence-based and can be compared against other performance of other medical facilities. We do see that 85% of participants who participate in this program already implement improvement projects based on what they saw in the benchmarking. And this is an opportunity for your medical facility to improve as well. We do have another improvement opportunity, and this is APIHC, Ethical Principles in Healthcare. Now, this is another sister program of the Healthcare Quality Advisory. It's a set of ethical principles that your medical facility may adapt and implement, and it's also a no-fee collective action initiative. And those principles help improve the performance. They act as a guidance for better decision-making, for mitigating ethical issues, and enhances the presentation to your boards and investors and associations as well. And again, this is a free program. Now, this is where you can take a screenshot and you can access information about those programs and understand how to join them using those 2 QR codes. So please have a second, take a screenshot, and visit the 2 websites of those programs as well. What we do after the webinar, when the webinar ends, we ask you to fill out a survey on exit, to share your experience and to tell us what else you would like to see covered in our future webinars. It is important for us, and in exchange for providing you with valuable and useful information today, we ask you to share your experience with us. Okay, and this is basically it. And I'd like to welcome you to today's webinar. It's a fireside chat, and we have excellent presenters and our facilitator, Julia Kalimova, online. Thank you very much.
Thank you very much, Natasha, for your introduction. Hello, everyone. Nice to have you again here in IFC webinar. Thanks for joining. Thanks for being active in the chat. And today, actually, as Natasha said, is not quite a usual webinar. It's also a knowledge sharing event. That's what we try to be consistent here. But what we wanted today, we wanted to share some very nice stories, some very nice cases of quality improvement projects, and to demonstrate you how quality improvement can result in increased access to affordable care and how it can lead to better outcomes for patients. We believe that these stories, kindly told by our participants today, will inspire you, and maybe you also do something similar or maybe something different, but also start improvement projects, and you will see that that actions can be very fruitful and lead to these wonderful results of improving outcomes and increasing satisfaction of patients and increasing access to quality care, which is very important in emerging markets. So I'm happy to introduce our first participant today, and the project is called Aldea El Foco. And we have the team today, actually two representatives. So Frank, over to you, please. Can you kindly give a brief overview of the project, what you did, and what happened after the improvement, as a result of the improvement? And I kindly ask my colleague Siko to share the slide for. Thank you very much.
Thank you, Julia. I'll pass it on to Caio to explain about the Aldeia em Foco. He's the president of Instituto Suala Bujanga, Institute 100% ophthalmology here in Brazil. And Caio, I'll pass it to you.
Hi, Julia. Hi, Frank. First, I want to say thank you for the opportunity to be here and share a little bit of our knowledge and what we develop in eye care access with indigenous people. So I want to just take a background from where the project started. We work for a eye hospital in São Paulo, in Brazil. I am the president of the eye hospital. We are the largest provider of eye health service that work in partnership with the public health system here in Brazil. And in the past, me and Frank used to visit villages, indigenous villages all over Brazil, and try to give assistance in eye health for them. But we have a lot of difficult problems when we talk about logistics. And from this point, we understand that we need to change our perspective and the way we bring our service to these communities. So in this moment is when the Aldeia em Foco projects, that when we translate to English is Villages on Focus. It's where the projects begin and where it's born. So we created a new model that we use a lot of portable equipments to take these equipment with us to the village. So the big difference here in this project is not because even when we go to an indigenous area, is like really, really big. So it's really hard the indigenous came from their village to this point for this main point of service that we established during the expedition. So now with this portable equipment, we are able to go inside of the village and give us assistance for all those people. So we can screen and make exams for everybody. So our project, we make the first consult of ophthalmologists with fundus camera, tonometry, a portable sleep lamp with AI. The fundus camera has AI as well. So we can make this first assistance with a really good setup of equipment that we understand that can give us even for anatomy, but at the physiology of the eye, and understand if the patient has some kind of problem. With that, we have as well a partnership with Good Vision. It's a Germany foundation who give us the $1 glass. It's like a Lego glass, spectacles actually. So we can, for monofocal vision, we can deliver the glass at the moment. So we can take all this setup and the glasses, and we can give assistance for these indigenous people, make the visual acuity, understand if the patient has or has not a problem. After that, we make all the exams. So we pass through the tonometry, to the fundus camera, to the slit lamp, with the autorefractor. And after that, the doctor, the ophthalmologist, we take them with us to the field. We pass the patient through the doctor, and we understand the refraction error and donate the glasses at the moment. If this patient has some kind of special need in spectacles or for treatment, we send the spectacles 30 days after the assistance by FedEx or something like that we use here in Brazil. Or if he needs some kind of medium high complexity assistance, we refer them to the public health systems nearby the indigenous area. And now we are developing a new model that works with teleophthalmology. So because we understand that the biggest challenge that we have is the logistic problem, because it's really hard to access this population, and the second one is the cost of the doctor, because it's the after the logistic, the doctor is the most expensive part of this project. So we are trying to develop a system that we can take just the technical team to the field, and the doctor stays in São Paulo and make all the assistance and the refraction by this teleophthalmology system that we are developing. So I think really a really short way to explain the project that we are doing is like that. But I think, Frank, I think you can complete me with some more details of how we approach the communities and everything, the politicals and the numbers that we already reached in 2024, because it started the beginning of the last year, this project.
Yes, thank you, Caio. This project has begun last 2 years ago, and I've been working almost 10 years in indigenous communities. And when I met Caio and the institution, I saw that the institution was the most capable institution that can get this project done. And when we started, we got funded by the Japanese government fund through the IDB Lab and L'Occitane Foundation, where we were really, like Caio said, that we were really having problems making the patient come to us. So we created a project to taking the outcome to the patients and not the patients getting to the outcome. So this is the project objectives, and it has really, really good results until now. So we attended more than 12,000 people already, and we already identified 7,361 people with vision problems, gave 6,300 spectacles, and referred more than 2,000 people. I think that, yeah, this explains a little bit about our project. Thank you.
Thank you. Thank you very much, Frank, and thank you very much, Caio. Please don't worry, we'll definitely have a chance today to discuss the project in detail, because that's why our event today is called a chat, because we want to give audience an opportunity to ask lots and lots of questions about various aspects of the projects that you initiated. And also I, as a moderator and facilitator, will be asking maybe some tricky questions to you, just to better understand the innovations that you used, and also again to inspire our audience to change. So now, Siko, kindly asking to move the slide to our second participant today. And I'm happy to introduce a second project, a second case. And Pininia, over to you, please. That's Avenue Healthcare from Kenya. And Pininia will tell you the details about the projects, the improvement projects that they created. Thank you.
Hello, good afternoon, and wherever you are, greetings of the day. Thank you so much, Julia, for giving me this opportunity also to come forth and explain, or rather just tell the audience what Avenue Healthcare has gone through and the reason why we decided to have a project on maternity program. So Avenue Hospital, just for introduction, is a hospital, a level 6 hospital located in Nairobi, Kenya, which is the capital city of Kenya. So at Avenue, we have, I said it's a level 6 hospital, but also it's a teaching hospital, meaning that we have doctors who are training with us, who are rotating with us, and nurses and other cadres in place. It is a hospital that has got a capacity of 130 beds at the moment. A hospital that started as a family business right now is a multi-speciality hospital looking to have very complex, cases and procedures that we do within the hospital. And at the moment, we are looking to expand the hospital even further than this. So the reason why we felt that it was important to put up this program, it's because we had suffered very bad outcomes of maternity in our organization between the year 2020 to 2022. And we were experiencing very high numbers of sentinel events, and most of these sentinel events, around 75%, were coming from the maternity department. And we felt that it was important for us to dig deeper to just to establish the reason why we are having these bad outcomes. And some of the things that we found or problems that we encountered at that point was in terms of structural makeup of the hospital. We felt that the patient in the maternity department, and this, most of the feedback we were getting from patients is that they were not happy coming to deliver in our place, in our hospital. First of all, because the word out there, and I mean the patient word out there, was not very good because of the outcomes. Remember, when a mother comes, delivers, and does not get very good outcomes, they get out there and they tell everybody out there that the hospital is not good for us to deliver. First of all, we did not have any privacy within the hospital. Mothers would come and deliver, and in a one delivery room, and mothers would labor in one labor room that had many other beds, so there was no privacy. And then in terms of equipment, we did not have the right equipment, modern equipment. We had very old equipment in the organization. We did not have any report on how servicing was done and repairs. And in terms of systems, then we did not have any electronic medical record in place. We relied fully on paper, and therefore it was very difficult to even follow through how mothers were monitored within the maternity department. So we also had issues with staffing, and some of these challenges that I'm pointing out here, we only had to establish that we had issues by mapping out our risks within the organization. And a maternity, of course, became the top in our risk register. And therefore, it meant that we get deeper to understand exactly what steps we'll be taking to be able to address the issues. So in terms of staffing, we really had a critical shortage of staff, both for the midwives and for the obstetricians. We did not have anesthesiologists in place. And in terms of training then, we did not have staff who had skills that were needed to manage a maternity department. In terms of theater, we did not have a maternity theater that was ready at that time. So meaning if we got a complication within the within the maternity department, then we would not address the emergency at that particular time. So that led to bad outcomes at the end of the day. So what did we do? We had to work on the key performance indicators, and just to narrow down to maternity, we were going to start monitoring our maternal outcomes, maternal mortalities, neonatal mortalities, and the complication overall complication rate. Primary cesarean section rate and satisfaction for both the staff and for the patient. I've tried to rush through. Julia, back to you.
Thank you very much, Penina. Thanks for this overview. And just also to explain to our audience this time, because it's a different format, we have just one slide overview, which demonstrates the key features related to each case. But don't worry, after the event, we will share all the presentations and all the materials shared by our participants today. So you will have a chance to have another look at the materials and the slides. The reason for that was that today we wanted to devote most of our time to discussion so that we see all the aspects of the cases and all the aspects of the improvement projects. Also, you can see that on our slides, importantly, we have the area identifying the challenges. And this is that I'm sure all the facilities face in their day-to-day activities, especially in emerging markets. We all have challenges, and the purpose of today's event is to see how these challenges can be solved and how they can be overcome, and how to initiate an improvement project. And that's what we will be discussing today in detail. And now I'm happy to introduce our third case, EHA Clinics. Siko, can you please share the slide kindly? And Aisha, over to you, please.
All right. Thank you, Julia. Good day, everybody. So basically, EHA Clinics is a GCI accredited primary healthcare facility in Nigeria. And we are cut across seven locations in 3 different states. We have about 5 primary care facilities and 2 community clinics. And our mission is to provide quality, accessible, and affordable healthcare to all communities. And our model is really around patient-centered care, which means that, the patient is at the forefront for every service we offer. And, we try to offer the services at the utmost convenience of our patients, right? Also, our approach is around digital innovation across healthcare in any way that, we could afford this. So the clinic was founded in 2018, and of course, incorporating digital innovation, we had incorporated using an EMR, which is an electronic medical record, right? And while adopting the system, we sort of noticed a lot of challenges with the existing EMR at the time, which had a bit of fragmented care, which means that we're not able to merge all the data records from patients that visit each of our clinics into one. And there was this, obviously this would increase, high wait time for patients because you're trying to get data from another clinic, right? We can imagine how frustrating that would be. Another thing was also, continuity of care, which meant as our system, if we want to have a patient-centered care, we need to ensure that there's that continuity of care. And then that was really another problem for us. We also had difficulty in obviously tracking patient outcomes and also trying to get this data across. So in 2023, we decided to build in our own in-house EMR. And we noticed that this was quite a challenge for us, but then we are very, open-minded, and then, quality is at the forefront for our innovation. And we decided to adopt this innovation and quality improvement project by using our existing resources, who are our software team in-house, to build an EMR that best applies to us. And, of course, we figured a lot of, innovations around, incorporating a lot of, insights from our users who are primarily the staff of EHE clinics to ensure that this solution is built to perfection. Of course, also we noticed a bit of a gap in mental health screenings, especially because, in Nigeria, we have a lot of cases that are very undiagnosed on mental health and also untreated. So we needed to figure out an innovative way to incorporate, mental health, screenings to our day-to-day visits, in the clinic, and also ensure that, we try to cut the barriers of the complex information where we get this in Nigeria. When you talk about mental health, it's not really widely accepted. So we need to sort of bridge the gap in the cultural barriers, but then also make this innovation tool very flexible. So that's about it. And then, over time, of course, we've seen series of improvement where we're able to screen about 20,000 patients in our system. Our solution has brought about, a centralized system where we're able to access this patient medical records across all our clinical locations. We're able to also, deploy our quality improvement efforts by incorporating, a quality app in the EMR. So the EMR is called EHA Care. So we're able to incorporate that in the app. So we're able to make, seamless audits, around the different locations. And also we incorporated clinical guidelines and best practice to the EMR to ensure that, doctors have the right amount of information to deliver the best care to our patients, right? Also, we're able to automate workflows, operational workflows for our patients, and then try to minimize waste in the existing process in our system. So anything that, a computer could do, we're able to sort of incorporate that into the EMR to ensure that we have, more productivity and efficiency in our processes, which obviously would lead to a shorter wait time, 80% compliance to medication, also to chart completeness from the doctors. So that's just the background of what this innovation is about, and I'm very sure that we are going to be able to dive into most of the informations around what the solution is. Thank you, Julia.
Thank you very much, Aisha. Yes, we'll definitely do deep dive into the details. And thank you very much to all the teams today for the introduction. And actually, you already partially answered my first question, which was why did you choose this project? Because to implement, yes, because you already described the background. Thank you very much. So I will slightly change my first question then. So I worked in a hospital in emerging market myself, and I know that usually you have often more than one challenge. So obviously you have a problem that your patients face, or you faced with patients, or maybe have patients complaints or problem with access, but also others. So why did you choose this specific project as your priority one? And maybe you recommend, yes, how to prioritize areas for improvement. This is part one of the question. And part two of the same question would be solution. Did you invent your own solution for this case? And also would be interesting to know how. Did you brainstorm as a team? Or maybe you or somebody like a local genius had one solution, or maybe you were inspired by similar projects that somebody else did. Maybe you read an article about such solution and also decided to implement it. So it would be nice to talk about this part now. Who wants to be the first?
I can go first.
Yes, please, Aisha.
Okay, so yeah, so of course, the first question, if I'm correct, is, why we chose this QI project, right? And, of course, I had mentioned this in the introduction of how frustrating it was to sort of access patient data from another clinic of ours. And we understood that in order to provide, comprehensive quality care, we needed to create a system, or more like a repository, where you're able to find all the data, information, patient history, patient medication management, and all that, especially for chronic disease management, right? You need to have all those follow-up plans and all that. So I think that was the first space where we knew that, we need to sort of provide a solution to this. And like I mentioned, EHA is a very, we have a very high concern for digital innovation, and then we try as much as possible to come into trends with all the innovations that are happening. And we just had to think about it. And of course we had a brainstorming session, and the brainstorming session would obviously include our dear patients, from the feedbacks we get, what are their issues, and what are they going through. And most of it would be obviously around wait time. I think that's like a big frustration for most hospitals. And of course, we needed to give them something that they're able to sort of access in their home. So there were questions around, in terms of convenience. If one of our model is patient-centered care, we needed to think about convenience to patients and how do we make the experience a very good one. So we talked about how they want to have like something they could go through, so they could get their patient records through like an application on their phone. Then also we talked about how in the clinic also we got feedback from our staff on how better we can improve in our process, because part of EHA's true north, on which is more like our objective, is on quality, right? And we have quality management systems in place to ensure that we always uphold quality in everything that we do. So one core quality management system that we abide by is the lean management system. And when you talk about lean management system, all it talks about is trying to remove waste in all your operational processes. It could be from a person perspective, it could be from a system or some sort of protocol that you have put in place, but it's just more focused on problem solving. So of course we needed to go to the people that we would use the system at the end of the day to ask them, how are we going to better improve your system? Where are the gaps you have in ensuring that your workflows are more efficient? How do we ensure that patients don't spend a lot of time in the clinic, right? And we went through that whole brainstorming process with also the clinicians in our clinic, and also the front desk as well, right? They are the ones that receive the patients, they are the ones that help manage the patients. So we had a whole brainstorming session around this. And I think one key strength for us was the fact that we had our software team in-house. So there was always these iteration moments, there was always feedback loops, very open dialogues where our staff were able to sort of speak about the EMR that we built and, let us know, okay, do we need to tweak this a bit? Do we need to, enhance it? And do we need to? And then it's just all about small improvements. So it's not really about the bigger picture. So there was always that, open space where they were able to sort of speak to the software team on how better to improve on a weekly basis. So I think I'll stop here for now. Thanks.
Thank you, Aisha, for a wonderful detailed answer. And I think involving patients is a great tip, really, into brainstorming, because this creates really like a multi-dimensional view of the problem, and they really can come up with certain solutions. And by the way, congratulations on the average time of 18 minutes waiting time, because waiting time is one of the key problems for multiple facilities globally. And that you were able to manage it means that, yes, it's possible to manage it. Although some facilities, they say, oh, you still cannot change it because it exists everywhere and you cannot address it because it's so complicated. Well, you demonstrate that it's not so complicated. So well done on this. So Frank, Kayo, do you want to be the next? Why did you choose this specific project and how did you find the solution?
Okay, so actually, we choose the indigenous population first to give assistance because we understand that they have this necessity. It's really hard to get any kind of treatment for those people in the middle of the forest. So and when we understand, like WHO says that 80% of the blindness in developing countries could be reverted if the patient have access in the beginning of the treatment. So it's not about it's really hard to revert this condition if we give assistance in the beginning or if we give the primary assistance for everybody. And we already had the setup of a standard setup that we use in the hospital, but that not was this kind of setup was not don't work with this kind of situation. So we choose the indigenous population because we understand that they have a really high impact if we give assistance for them in the eye health. Here in Brazil, the deficiency of eye health in eyes, like the biggest deficiency that we have, and we understand this kind of population is really ancestral. So they use a lot of like the vision and the hands to work with, to fish, to hunt, to make all the manufacturing that they sell. And so it's really important, the vision for those people to have like a really quality of life and like a daily life. And that's the reason we choose them. And when we start to brainstorm and understand which was the best solution for this problem, we start a conversation with Ministry of Health in Brazil, and we call the private sector, so the industries, to understand which were the best setup of equipment, because we already understand what we are doing. We have like the first consult is the best. We already have the protocol, so we follow the protocol. We use every kind of projects that we have, like decentralized projects that we do here in Brazil, but we need to understand which were the best setup and equipments that we should bring with us. So we call the Ministry of Health representative, and we call some industries and start to ask them which equipments that they have to offer to us to put in this project. And so we make like a partnership or a brainstorm with everybody from the first sector, the second sector, and the third sector, to understand what is the best solution to develop, and then start to running the project after that.
Thank you. This is wonderful. And also, again, you used this multi-dimensional approach. Yeah, so brainstorming, so team approach. This is a great demonstration that team approach works. Team approach works in solution. Finding, even if there are no similar projects globally yet done, still working jointly and involving multiple parties, yeah, from different stakeholders really helps to find a unique solution, yeah, which never existed before. So if you want to improve, this is a message for our audience, if you want to improve something and be the first to do it, nobody else has done it, don't be afraid. Just use the team approach. And this is, I think, very important message, really. So, Penina, and by the way, I know that many of our participants have multiple projects apart from the one they are presenting today, and we'll talk about it a little bit later about other projects. And Avenue also has multiple projects, so probably we shouldn't address why you chose this project, because you already told us. Let's maybe focus on the solution. So how did you find this solution? Again, maybe you used some sources for this, or was it your own uniquely created solution?
Right. So from Avenue, I will just mention that Avenue has been through the quality journey all the way from the year 2018. And there has been a deliberate intention to change how things are done. So for us, we were able to identify problems through measuring. And I will say that if you don't measure, you cannot improve what you do not know. So first of all, it was, is a quality framework in place already? Yes. Have we defined exactly what we are measuring from each department? So this is how we were able to identify the problem that we have been working on. That is basically in the maternity department. And I said that, high numbers of maternal mortality, neonatal mortality, and overall complications in the department informed us that there was a problem that we needed to investigate further and find solutions. So the other thing that I will mention is that once we have collected data, then we needed to dig deeper through root cause analysis, and the results were shared always to the leadership. And what was very outstanding is that the leadership was always ready to support the action plan or action points that we came up with. And that is how we've been able to succeed. So over time, when the quality journey started from 2018, we were able to get accredited for the first time by COSASA in 2022. And right now, as at late last year, we got a reaccreditation with a very high mark just to validate that the services that we are offering are actually good services. So measuring is one of the things that informed us that we had a problem. Then the outcome of care, of course, and also what were patients telling us about our services. So we listen to patients a lot. We listen to our staff through staff engagement and patient engagement. We were able to tell that we actually have a problem, and looking at our NPS that was ranging at around 40%, 40s, we were able to bring that up to 80, an average of 80. So meaning that there's something patients were seeing about us before we delve deeper to understand exactly where do they see the problem. So we were able to address staffing issues, we were able to address skills issue, we were able to address equipment issue, and overall, I think that's how I would answer that question. But it all started with the intention to change.
Thanks, Penina. And by the way, a special thank you personally from me for stressing the importance of measurement. We talk a lot about it, that measuring quality indicators is a very powerful improvement tool, but not only measuring, but also comparing them to others, to like doing benchmarking, to the target numbers, and also doing the root cause analysis if there are any significant changes, and implementing corrective actions. In this case, measurement becomes very, very important diagnostic tools that can tell you exactly which areas require attention. And thank you very much, Penina, for stressing that. Also, you partially answered my next question, read my mind. The question was about management support and staff resistance. We all know that sometimes staff are overwhelmed by their daily activities, and also they might be resistant to change because they are already accustomed to the daily routines and they don't want anything new, anything else. So to be added to their job responsibilities. So improvement projects are sometimes perceived as additional burden. So we will be very grateful if you share your experience. How did you bring staff on board so that they become as motivated as you are about the change? And also, Penina already described that management in Avenue was very supportive. And what was the case in your facilities? Did management support? And if not, how did you bring management on board to make them supportive?
Okay, so I think I'll go and answer that question. All right, so yeah, like I mentioned, EHE Clinic's true north is quality, right? And after quality, we have patient safety, we have customer experience, and so on and so forth. So at the topmost part of quality, of course, if this is what we abide by, we need to obviously put in systems for it. As earlier mentioned, EHE Clinics is a JCI accredited facility. So, and JCI is also a unique organization that really looks at, the quality outcomes of patients and ensures that, you also go by, quality standards. So these are one of the standards that we adopted at EHE Clinics. And of course, we also have the lean management systems as well, just to help with problem solving and, eliminating minimizing waste as we go. So yeah, of course, from the staff side, you have that resistance to change in terms of adopting the tool. But what we had done was that, we needed to ensure that there was this consistent coaching and, ensuring that, what we're doing is of their best interest. And that was why I'd mentioned that, we had those sort of discussions with our staff to even understand what the problem is and if this innovation even makes sense to them. Right, asking them about their problem areas, and of course using the tools that we have in the quality management systems that we've set up, which is around root cause analysis as mentioned, A3 thinking as mentioned, and then incorporating these tools to derive to, more sustainable outcomes, right? And like I said, the key note here is to always improve, right? So we had that buy-in from staff because we took this model to the staff. At the forefront, the staff understand that, at EHE clinics, this is what is our, core responsibility to our patients. And whatever we do is at the betterment for our patients and the staff as well. So it's not really about just really bringing in an innovation that would obviously benefit the patients, but also would benefit the staff. So I think those are one of the few things that we had done to ensure that we had buy-in from staff, and then of course opened communication where they're able to speak up about if there are issues in the system. We try to fix it as much as possible, and then also giving their room to even give their ideas on how we sort of innovate the different tools that we incorporate into the system, right? So for the management, of course we needed to have management support. But then we're also very fortunate to have our leadership buy-in, at a very good stage. The management was, giving their overall support to this. And we all know that, for quality to really be implemented in an organization, you need to have that buy-in from the top, which is the leadership, right? And these are the people that will sort of drive this into the teams. And then, whatever tools you teach the staff, they're able to sort of, provide their support in ensuring that there's compliance and, there's always opportunity for growth in the system. So yes, we had management support. They were very helpful, ensuring that whatever quality management systems we bring into the system, they were able to provide support to ensuring the sustainability. And then of course they were also very open to staff, really to hear from staff in terms of ideas for future improvement. One of the tools that we also used at EHE clinics is the daily management system, which is like a tiered huddle management system where staff can actually reach out to the leadership in terms of what are the ideas that they have, what are the thinking, what in terms of the day-to-day activities when they see patients, where are the ideas they're able to sort of incorporate in terms of innovation to better assist patients. So yeah, thanks.
Yeah. Thank you very much, Aisha. This is very impressive. Yeah. And all the interaction mechanisms that you describe, and especially the opinion of staff and also the innovations recommended by staff, if they are respected by the management and heard by the management. I think this is really very powerful instrument of motivation for staff. Really, in this case, the whole organization, the whole company functions as a organism, as a one body. Kayo, will be interesting to hear your opinion because you are management yourself. So it will be viewed from a slightly different perspective. So what did you do specifically to support this project as a manager, as a top manager? And also, did you have any problems with staff buy-in and how did you solve them?
Julia, I will pass the word for Frank because he's coordinating the project closely than me. So he's really close to the project and helping to solve all these kind of situations.
Thank you, Kyle. Thank you, Julia. Yes, our management team was very supportive of the initiative, recognizing the immense need of this project and potential impact of improving eye care access to Indigenous communities. And we actually created new staff for this outcomes. We go every month for 2 weeks outside of an institution. So it's not everybody that really wants to go. Some doctors or technician doesn't have that. They can't kind of get out of the comfort of the city and go to remote areas because it's a long drive to get to the indigenous communities. And also the places that we sleep, we eat is not that same thing as a city. So we take all of that comfort to get to those places and attend those indigenous communities. The staff member were also enthusiastic and committed to the project goals. While there were some initial logistic challenges and concern about the resource allocations, open communication and collaboration really helped us because we really got a lot of feedback of the people that went to the outcomes so we can get better, always get better. So each month that we go, we do a kind of like a feedback with everyone to see what we can get better, and so the project gets more structured. And it really helped us overcome these problems and ensure broader support for everyone. And also, we created kind of a medical committee and scientific committee so we can gather data and, of course, public, what do you call it? Make some papers to publicize everything that we do here in the indigenous community.
Thank you. Thank you very much, Frank. Wow, this journey that your staff had to go through, those who go to indigenous communities, this really sounds like a challenge. Yeah, and you really need to leave zone of comfort to start working there. So this is really impressive. And this relates to my next question. And just a little bit of background. And by the way, appealing to our audience today, please type your questions using Q&A button. I saw that you already started doing that, but you are welcome, because after we stop this discussion facilitated by me, when I ask the question, you will have a chance to ask your questions, and I will be reading them from the Q&A section. So please make sure that you post your question in time so that we had time to cover it and ask it to our wonderful speakers today. So speaking about challenges, when we start improvement projects, again, based on my experience, we usually believe, we hope, fingers crossed, everything goes smoothly. And if it doesn't, it can become very demotivating, again, for everyone, even for the management, for the staff participating, yeah, when your efforts do not bring the result you expected. However, challenges, I believe, are a normal part of each journey, and rarely we have ideal projects without challenges. So let's talk about that. We already partially covered it with Frank. So what other challenges did you have on your journey while implementing this improvement projects? How did you overcome them? And maybe even give some advice to our audience today, yeah, how not to lose the green light at the end, the ideal target that we have in these day-to-day activities, yeah, which might become very tricky sometimes and not as we expect.
Yeah, so can I go first? Yeah, so some of the challenges, of course, that we encountered was resistance to change. That was the biggest challenge. And mostly the resistance would come from other professionals, and mostly from the physicians and the consultants. I will say that largely, and I think traditionally, for all hospitals that have succeeded or that have some sort of quality happening in the hospitals, mostly the quality agenda is pushed by the nurses, because being the largest population of any healthcare facility, of course, this is the team that normally takes up that role. So for us, we would have, everything done, KPIs that we've already worked on, defined, well-tracked, and everything was working very well with the nurses. But when it came to doctors, it would have a problem. Sometimes, when you want to measure some specific KPIs, like say, for example, as simple as even hand washing. A consultant would ask you whether they went to school for more than 10 years to learn how to wash hands, say, for example, if you're doing things like, safe surgery, they do not want to give you a lot of time for you to, they say you're wasting their time, all the surgical safety checks that we are doing. So anyway, how did we bridge that? So that I give the rest time to talk about their challenges. We had to strengthen the clinical governance for the organization. So meaning it is well defined, do we have unit managers for every department? And more so, I will be very specific to my project, maternity project. So we had to make sure that we have a unit-led, a physician-led department. So meaning we had an obstetrician who is a professor of obstetrics leading the department. At the same time, we have a nurse unit lead. So meaning now that is to be able to strengthen the collaboration between the physicians and the nurses. And that for us really worked very well. And when it came to now the departmental and the quality committees, say, for example, the maternity users committee where these issues would be discussed, then it is the team on the ground that is discussing that the meeting would be held monthly. And then we would also have another meeting that is held quarterly, where now the heads of department, the obstetrician being one of them, the pediatrician for the PEDS department and those other departments, surgical department, would now meet in a MAC, Medical Advisory Committee, where these issues now would be discussed, and then eventually would have an annual meeting where we are having the quality council of all these departments and all the hospitals, because we have quite a number, coming together to discuss matters that ail the departments. So that way then, we've seen a lot of commitment and a lot of, people taking responsibilities and holding people accountable for some of the, gaps that are existing and are not being solved for long. So that way then, we were able to achieve a just culture, which I will say, we might not be there as per se 100%, but we are somewhere because right now everybody is cognizant of what is supposed to be within their territory. So apart from that, we also had issues with technology. We had very old equipment in place that would not help us to be able to, access data and make decisions that are driven by data. So that way, we were able to purchase quite some modern equipment. And right now, every delivery room, every labor room is equipped with equipments that are, and we have a system in place that is called radar system that is now connected to the equipment. So any obstetrician, even away from the hospital, can be able to see exactly how a mother is being monitored, is able to see early warning signs that can be able to inform us that there is an issue, a complication that is about to set in. So I'll leave at that. I have many challenges, but let me leave the rest for the others to also speak for themselves. Thank you.
Thank you, Penina, and thanks a lot to all the participants for being so open, talking about the challenges, because always we have desire to look a little bit better than we are, to look ideal. But thank you very much for revealing the real life problems and talking about them openly, because this is very important, we believe, for all our audience. Because again, when I was a quality manager in a hospital chain in emerging markets, I was thinking, oh my God, we will not be able to make a very strong improvement project, so better not even start because we don't have capacity. There are challenges in daily activities, while other hospitals that were demonstrating much better performance. So I was thinking they are stronger. But when they started to talk about their daily challenges, I realized that we can also be like them because they also had problems. They are not ideal. And knowing that sometimes becomes a very important push in decision making, to start acting, stop being afraid, stop being resistant to change and thinking that others can do and I cannot do. Knowing that yes, problems are normal part of any development. The question is how you overcome them. And every leader, every advanced hospital was also facing challenges at certain part of their journey. Okay, Aisha, over to you, please. Let's talk about the challenges you faced.
Okay, thanks, Julia. I think one thing I didn't mention in the first in the question before was also around the management support. So of course, many people would ask, how are you able to build a whole EMR without, infrastructure support? So yeah, so we're fortunate enough to have like our management also adopting this major QI project by fully investing in the infrastructure. So just to put a keynote there. So in terms of challenges, of course, the first challenges would be resistant to change. Like you're bringing something new. This is something that we don't understand. This is something that, staff would be like, are you going to add to our problem or are you going to solve our problem, right? But I always emphasize in the culture of small improvements and problem solving. And this is, the culture that we always drive at EG clinics, right? So it was more from, how best can we improve? And you don't have to get to the best improvement at the first stage, which brings me to the introduction of A3 thinking, which means that, the idea of it is to adopt a tool. So we adopted a tool, which is the PDSA. And, what a PDSA does is that when you get to the act and adjust phase, you're looking at all these plans that you've had, like, how are you able to improve, and, the targets that you've set out to improve at the end of the day. So say, for instance, you put out a problem and you say you want to resolve it in 3 months, right? So the act and adjust phase will just help you to sort of analyze if you even there yet. And then, of course, if you're not there, it also creates an avenue for you to go through the PDSA cycle all over again, right? So that's also one way that we were able to sort of put that, resistance to change, to ensure that, staff are able to, look at the fact that they are able to improve, for every PDSA cycle. So I would say that the EMR project that we had did not have one PDSA. It was more from an angle of, continuous improvement, as we build this tool. Then also, we also looked at, what their system is like streamlining what their workflow is, right? A lot of times, when you have a lot of patients and, we tell the clinicians, you have a lot of patients and, we had to speak to them in a form of letting them know that what we want to create is to also sort of reduce the influx of patients that they have, right? And, for instance, for a consultation to happen, you don't necessarily have to come to the clinic, building the tool that we've built. You could have like a telehealth conversation, which is at the forefront of your home, and you don't have to come to the clinic for that. That alone can reduce the amount of patients that would just come in for just a follow-up call, or just come in for just a very quick check, right? We also incorporated digital health too. So at the palm of your hand, you're able to see your vaccine records, you're able to see your patient history, and you're able to see any medication management that you have. Then also we looked at, in terms of the waiting times, right? How do we have visibility of all the different points? So an example would be when a patient comes in, how do you also measure the time that the patient gets to see a doctor, right? And this is how we're able to incorporate it by putting in a dashboard on our EMR that clearly shows you the number of times. But as much as possible, we also had to speak to the teams to agree on, more realistic time that a patient has to wait at your station. So as a front desk personnel, we're able to engage you and ask you, how long do you think a patient would stay with you based on, all the activities that you have to do? You have to check in the patients and all that and take their, information. And let's say it was 5 minutes, and we put that 5 minutes as a target for us in our key performance indicators for the front desk. So the front desk officers were also held accountable because they were the ones that advised on the number of minutes that it would require, right? And of course, the idea was that for every process that you have, on your station, if you're able to sort of automate that workflow, we were here for you, because obviously, as much as you automate, you're able to reduce the amount of time that would needed to, of course, to improve in your process. So that's also one way. And then, of course, that had sort of reduced our patient wait time for every station. So these are measures that we had put in place for every station, from doctor to nurse, from nurse to lab. And, everyone was held accountable for their key performance indicator. Also, the frequency of training. So the idea was, for every time we incorporate a new system in the tool, we always train, and then there was always an open space to retrain. We also developed, training modules for them, so they're able to go back and, refresh their minds, in case they forget some things. of course, they were able to ask any questions from either of the, teams that have built this tool. We also, another way that we did this was also in terms of documentation for the doctors, right? We had to also speak to the doctors in a way that we were trying to build a tool to help their documentation completion, because most of the time, doctors would mention that, when I see a patient, I have to document everything and it takes a very long time. So the EMR that we had built was in such a way that, we ensured that, it's easier for the doctor to put in things. So it's just as easy as putting in like automated fields for things that, they can just, click on a button and then they're able to just put in there. So instead of, typing everything that they need to type. So those were, some ways, even in terms of clinical decision support. So we obviously integrated, BMJ best practice, which is an external governance, and we put that into our tool, so that way it's able to help clinical decision support in case obviously being diagnosing a patient and you sort of forget one or two, you're always able to go back to that clinical decision support to get few ideas, and of course that would improve health outcomes. Then in terms of mental health services, there's obviously the stigma to what is mental health? Am I going crazy? It's very, very high. And I think based on statistics, we have about 20% of Nigerians going through this, as easy as depression and anxiety. And we needed to sort of breach that gap of stigma and, limited awareness. So what we had done was to incorporate, medical mental health screening tools, such as, I think, GD9. And these tools were supposed to be incorporated into your regular visit. So when I come in to see a doctor, you're asked, a few questions, and based on that, you're being assessed for mental health. And, we had to make it seamless enough so that it doesn't become, a separate way of evaluation. So the fact that we had incorporated it in our evaluations for every patient that come in, we're able to even diagnose a lot of people with mental health. Over, about 30% were even referred to, referral facilities. And then also, we're able to screen about 20,000 people about mental health screenings. So I think those are a few things that, we had done in terms of, the challenges we had and, the solution that we built. Thank you.
Thank you. Thank you very much, Aisha. And my next question is a little bit a tricky question. So we discussed all the challenges that you had to go through and also the solutions that you had to find, and also to bring staff on board, to bring management on board. Do patients appreciate it? And how do you know that they do? Can we talk about it? So did patients notice the change? This is important, yes, so that because patients' well-being is the actual one of the actual goals of the whole healthcare processes. Yeah, so how do you make sure that you really hear what patients say, yeah, and that your improvement project really leads to their increased satisfactions and better outcomes? And we'll talk about outcomes separately. I have a separate question on that. Because sometimes we can be a little bit misled by our own vision. Yeah, we can enthusiastically do certain things, but not necessarily they satisfy patients, right? So how not to make this mistake?
I go first? Yeah, so did patient realize the changes that happened, and how did they appreciate the changes? Is that the question?
Yes, exactly.
Yeah, so from patient feedback, of course, we are able to see a lot of compliments coming through. Say, for example, your nursing team was very good, your maternity department was the best, as opposed to kind of feedback that we were getting before we implemented the changes that are in place right now. So through Net Promoter Score and patient or customer satisfaction survey, we are able to tell the difference, because we grew from an average of 40, around an average of 40 to 80, and some of the areas that really had issues, for example, privacy, we did not, we addressed the privacy issues, and those are not complaints that are coming in anymore, even for the nurses, we've seen attrition rate that goes low. There before, nurses were not very comfortable working in the department because workload was just crazy. Can you imagine having a nurse taking care of 9 patients? So in the maternity department, remember, you are having a mother in labor. And when they get to a point where they're going to deliver, then it means that the nurse is going to leave all the other patients and go with the mother to deliver. So by the time she's coming back, complications have already set in. So we grew our nursing hours per patient days from an average of around 5 to 6 to 10. Now we are doing 10 nursing hours per patient days in the maternity department. So back to the question, are patients realizing whether there are changes in place already? Yes, we have had a lot of changes in the department, and even that is supported by the footfall that we have in place right now. Before the project, we were seeing an average of 50 patients delivering per month. Right now, we have over 180 to 200, an average of that in a month. And of course, the outcome of care, I would say that the problem that we have in place right now is a good problem because it's because of lack of beds. Most of the time, we are more than 100%. I'm saying more than 100% occupancy in the maternity department because, of course, there are those instances where you have an emergency coming in, you're delivering, but you're waiting for a bed to transfer. Thank God, because of this project now, we have delivery rooms that are fully equipped. So a mother is still comfortable in that department before they're transferred to a postnatal bed. So really, this is something that has worked for us. And it's a project that has been there for some time. We have fell in between, you have planned and it does not work, you go back to replanning. So, yeah.
Yeah. Wow, Penina, that's very impressive growth of the patient numbers. Wow. Yeah, that's amazing. Yeah, I think this is the best evidence, of good care and patient's choice. When they really the numbers grow so significantly. Okay, Aisha, what about you? Or maybe friend Kayo? Okay, Aisha.
Okay. All right. So yes, from the patient perspective, of course, the first space would be the surveys. So of course, when they come into the clinic, as you're going out, they have this barcode system where they're able to include, how their experience went, from stage by stage. And of course, that was, where we got very good comments from our patients, especially about the wait time, how we've sort of improved from a wait time between 7 minutes to about 18 minutes per patient. Another way was also medication compliance, right? Because now they're able to sort of see all the medications that they're required to take. They're able to get reminders beforehand. So especially for those with chronic disease care, we also had to put them in small groups, which we call like empanelment group. The whole idea is like a health tribe situation where we're able to give them, very close care, and they were able to see, their medication management through this digitized application. And then, of course, that increased compliance by 80% by the end of last year. Also, of course, the fact that, improved patient outcomes, patients were commenting that, they were getting a lot better. And even for cases where, follow-up plans are not met, we're able to, call patients every 48 hours to confirm if they're doing well, and they would require more assistance. If they need to book follow-ups, we're able to book those follow-ups for them at the moment. And of course, that has sort of increased our chat completeness for doctors, which obviously would help to improve the patient outcome, because now when a consultant is looking through, they're able to get all the information about the patients at least as accurately as possible, and that sort of increased it from an 84% to 91%. Also, for mental health screenings, of course, the idea was to access all patients from 15 years and above that come across our clinics, and we're able to meet that benchmark at 100% by the end of the year. So I think mostly was, really trying to incorporate all the issues that, patients were facing, and also giving feedback on, right? And then ensuring that we sort of improve and we hear them. And, of course, we had this regular communication with our patients on a weekly basis. It's like a digest where we also give them, updates on new tools that have sort of been incorporated, how best they can track their, outcomes, and how best they can access their patient records. So yeah, that's
Thanks, Aisha. Yeah, and I think it's a great idea really to interact with patients as much as possible, both at the level of initiating the improvement project, on brainstorming on the solutions. Yeah, first of all, it's also patients will be grateful that if they complain and they're not happy about certain areas, they will see that their opinion counts. Yeah, and you ask them, okay, let's work together. Let's brainstorm together and find a solution. And sometimes they give very valuable input. And then also interact with them. How happy are you with the results? This is really full circle. And I think it becomes really, this cooperation becomes really fruitful. Yeah, and really helps the improvement project to be successful. I think it's a great idea and really like a lesson learned and something to consider for our audience when they do their own improvement projects. Okay, Frank, Kayo, and what about you?
Engaging with the indigenous community was absolutely essential for the success of our program. And we work really closely to the local indigenous health authorities and the community leaders to understand the unique cultural practices, beliefs, and needs related to the AI. So this informed our approach to deliver to service delivery, and including the use of interpreters, especially because sometimes we don't understand what the patient are saying. So we have to use interpreters. Like here in Brazil, we have more than 200 languages, indigenous languages, instead of Portuguese only. So it's really important to those interpreters talk with us about the patient's problem. And we also made concerted efforts to build trust and effort with community members, such as holding town hall meetings. Before we go, we actually go there to talk to people, to see what they need, how we can engage, how we can plan and implement our program before the people that are going to tend the patients can go. So before everything begins, we also talk to them first before entering, and also getting their authorization so we can go there. And for more comprehensive approach, we are closely in contact with the Indigenous Health Council that ensures the participation of Indigenous people in the formulation of public policies, monitor, debate, and also present proposal of strengthening health in Indigenous lands. And I think those are the main things that we do before we engage with our program.
Yeah, that's a great point. Thank you very much, Frank. Now also, I think a very difficult question, very tricky one. In your cases, but very important for our audience, and I think for any improvement project, very important. So you demonstrated great results in your cases description that you submitted. So not only, and it was shown on the slides as well, not only your project helped increase access to healthcare services, they also demonstrated good outcomes, yeah, and also they are affordable solutions, yeah. So it's a win-win, really. How to make it work? So maybe you can share some secrets how to combine all of these important aspects, because each of them requires effort and each of them is a very important target, yeah, and focus in itself, yeah. But how to make all of it work, this really, I think, is like a secret of success, yeah, for everyone who wants to improve quality, healthcare quality in emerging markets. So how to combine it, and what secrets did you use so that you demonstrated such great results?
Okay, I think I can take that. Okay, so I think, like you rightfully mentioned, the fact that we have great outcomes, it's not like we started this QI project just 2 months before. This has been existing for years. Like I mentioned, the EMR was built in 2023, and like I said, what we obviously try to promote is also that culture of continuous improvement, right? And an open door policy where they see an issue and then they're very much assured that they are able to resolve it. I think mostly how to just do this is to really ensure that you implement very good quality management framework for your system, and ensure that the teams that you have also understand what those systems are like, and then the strategies that you've built around those systems. And the idea would be, an example for EHE clinics is, like I said, we have the lean management system that takes us through the A3 thinking and also the PDSA. And what the PDSA does is, PDSA, as it stands for plan, do, study, act, and adjust. When there's an issue on the EMR, coming from the patient perspective, maybe we see some sort of comments from our patients or even from the staff, like on the system, I try to put this and it's an error. The first thing they do is to report it as an incident, right? So we also have an incident management framework that helps people to sort of report things, so we're able to see it as early as possible, and we're able to resolve it, or we're able to sort of improve on it. So they report that as an incident from the patient or the customers, from the patient or the staff perspective, and then we obviously translate that into an A3, which is like the PDSA that I speak of. And this is where we put mostly stakeholders together, and then we dive into the problem. So what is our problem? What is the existing problem? And and we think about different tools to come about trying to resolve the problem. Also, we incorporate tools for the root cause analysis section, where we go ahead and say, okay, we know what our problem is. We also talk about how do we intend to achieve what we intend to derive. So an example would be a patient wait time, for instance. Your patients have been explaining this, that they're, tired of waiting for very long hours. And then, of course, your target to that is to ensure that patients have a good experience when they come. You also obviously would have to identify like some sort of metric to it, because I think metrics also helps you to sort of ensure that, you're able to monitor your progress in your quality improvement project, right? So you also have to put in a targeted metric. So for this case, let's say it's about 100%, and then of course you now decide to dive into the problem, where you use root cause analysis tools like the fishbone diagram, or other root cause analysis tool. So for the fishbone diagram, you look at different areas around your existing framework, how this ties to what this problem is about. Is it coming from a communication gap within the system? Is it coming from a system error? Would it coming from the management perspective? And we go dive in and we put in all this into the document. And then when we do that, we obviously put in a study phase. A study phase is where you've implemented all the solutions that you would like to implement. So we talk about all the solutions as a team, and we talk about what we think we can do to improve this problem. And then of course during the study phase, you put in a target period of your study phase could be about a month, for instance, and this is decided within the team, so that you guys are able to come back in a month and say, okay, we had this problem at the beginning and how far have we gone. And of course the targeted metrics would also help you to understand and assess based on the data provided in the EMR, to know how far this has gone, right? And the idea would be to sort of survey this, but then a keynote, like I always speak of, is to ensure that you have an open space to continuously improve. So sometimes you have QI projects that you don't meet your targets, but then nevertheless, that's not supposed to be demoralizing for you. The idea is that you just take in the small improvements. It could be that, one patient was happy, 20 patients were not. It just means that you have to go back to the drawing table and figure out better sustainable solutions to make all your patients or your clients happy. So the idea of, like I said, the PDSA is to just continuously improve, and then take the small improvements as wins when you're trying to build your quality improvement projects. Thanks.
Thanks, Aisha, such valuable advice. Thank you so much. And I 100% agree with you. Yeah, you shouldn't be demoralized. Yes, it's a challenge to combine different targets within one project, and it's fine if something is not going according to your plan. It's a journey. And be motivated by the little improvements. Yeah, thank the team for that, for them. And then just move on, and then you will see the results. If you continuously invest your time and effort into it, you will definitely see the results. Maybe a little bit later than you expect, but it's fine. Pinina, so anything from you or Kayo or Frank before we move to the next question? We don't have much time left, really. Yes, please.
Yeah, so to answer that question, Julia, I will say that we need to embrace a proactive and systemic approach to be able to manage patient safety and also to be able to identify risks and, deeply examine them and come up with mitigation measures. So when I talk about system approach, it is not just, there's no, for me, there's no incident that is superior than the other. What else are you measuring? So say, for example, and just to touch on, I know we don't have a lot of time, but there's also another project that we had done on how to, management of NCDs. NCDs, what informed us to come up with such a project was actually the number of patients that were leaving the hospital against medical advice. We had to look at the numbers. They were really growing very high, and we wanted to get deeper to understand, are we too costly for the population? And, in the locations, different locations, are we, is there a way we can be able to sit down, maybe listen to the community and establish exactly when they leave our hospital, then where do they go to? What is the reason as to why they are leaving? So first of all, number one thing that we were able to establish is that they were leaving because of financial constraint, okay? They were not going to afford our services. So how did we solve this? We came up with packages that were going to be friendly to the community around us. And we really looked at the major, basic tests that were supposed to be done within maybe, say, patients who are suffering from diabetes, from hypertension, and from cardiovascular diseases, and come up with just a package that addresses all this. We were able to narrow down to, telemedicine and telehealth in such a way that a doctor seated even within the hospital, they're able to monitor this patient from home. So a patient is taken through a way that they can be able to monitor their own sugars from home. They don't have to and this is the kind of feedback that we got later from them, that they appreciated that they are not going to use a lot of bus fare even coming to hospitals. Remember, these are old, patients that really need to also be accompanied to the hospital. So they do not have to inconvenience anyone else to bring them to hospital from the rural areas. So there are a lot of benefits, and that brings me back to my point of a proactive and systemic approach to manage all these risk areas and just areas that you need to be working on. Back to you, Ilya.
Thank you. Thank you very much, Penina. Wonderful, great explanation and great answer. Yeah, Kayo, over to you, please. You wanted to say something?
Yes, I think complete what Aisha was saying. We need to have a lot of metrics to follow up the project, understand where we need to focus our energy and try to solve the bigger problems that we face during we are implementing the project. But not speaking just about the Foco, but other projects that we have here in Brazil. I think one really important thing that we need to have is the culture of all the players that work in this team, because even if we are here in a top management charge, that we have some decisions that we understand that is the most intelligent one to do it during the project. We need to have this communication with all the team and all people that are working in this project, because they are facing and dealing with the patients in the other part of the project. So those people are who really can say what is the problem and what is the complaint that these patients are having and feeling. So then we start to have a brainstorm. And if you can transmit and say how important it is, this project, for those people, and how big it is, the positive impact that we can guarantee for them. So these people start to like really look with other eyes, like with another kind of approach for the project, and start to really feel part of something that is changing lives. So I think it's one of the, I think here in Brazil, for us, this is one of the things that we feel that all the organization that we have really have like this power to really touch inside of people that are working with us, and put them to work with the team, and like this kind of culture make a lot of difference in the end of the day.
Thank you very much, Kyle. We are running out of time, really, but we will take several questions from our audience. So thank you very much for staying a little bit longer. We will try to not to take too much of your time, but I hope you find this discussion interesting. So one of the questions we discussed already, patient experience, satisfaction, and patient's opinion about the improvement projects that facilities do. And an interesting question arrived on the different aspects that are covered by patient satisfaction survey, which might be a little bit subjective, and also versus patient-reported outcomes. So let's reflect on this, which is more conspicuous for us, which data we can trust, and which we should take very carefully, into consideration, and generally how to combine this data, how to know what is true, what is the true attitude based on your experience, and what do you use. Maybe you don't use patient-reported outcomes. That will be also interesting to know. Why not, if you don't?
Okay, so I think that's a very interesting question, because as you know, much as possible, you want to always keep patients at the forefront, which means that, in terms of, customer experience, you always want to make your patients happy. But at the same time, you also understand that you have due diligence to ensure that, the staff that you have are always happy as well. And that's where you have to sort of create that open door policy for a culture of, speaking up and culture of improving. So I think most of the time, of course, it's, as a clinic, right, our customers are the patients that come in to see us. And the idea would be obviously to improve based on the comments that they give throughout their experience. And then, of course, you get that from the customer satisfaction survey. But then how we sort of incorporate also from, the staff that we have is also to ensure that, for every time we have, cases of concern, we look at this from a culture of improvement, where we also even bring in the staff that may be affected to speak about the same problem themselves, right? And the idea would be for the staff to obviously be held accountable if, at any event, this was also a staff problem. And even if there was a patient's problem, right, we also try to take as much measures to ensure that, we have that, it's also part of our policy to ensure that the staff is always happy and is always having a good place to work. And then, of course, patients are also very comfortable to come into the clinic, which is like part of the code of conduct from the patient side and also from the staff side. So we ensure that we incorporate, what this patient, has also obviously complained about, but then ensuring that, the staff is able to speak up about their own side of the problem. And the idea is to sort of marry this, issues together, and then figure out a way to sort of improve on it, right? So based on, what this problem is, and obviously based on the peculiarities of the problem, would determine, what the solutions would be in order to ensure that, we have like utmost satisfaction, be it from the patient's perspective or being from the staff perspective. So I hope that was clear enough.
Sorry. Yes, definitely very, very clear and very helpful, Aisha. Thank you very much. So anything from Kayo and Penina, or maybe we move to the next question? I think then we can take the next. Yes, please, Kayo.
Yes,
sure. Go ahead.
I
please.
think we can take to the next question.
Okay, great. So the next question was actually, we discussed remote care, in multiple ways today. Yeah, and we received several questions on remote care, and I would sum it up. Yeah, like one question: how to make care provided remotely safe, and what tip, yeah, we can have in mind while providing a remote care so that it does more good rather than damage the patient. Yeah, and this includes these travel camps, yeah, and going somewhere into the fields to provide care, how to make sure it's safe, because it's not a medical facility, right, condition. Same that Penina was giving, sorry, Aisha was giving example, yeah, and Penina was also giving certain examples. So how to make sure that remote care provided remotely is safe. What the tips and tricks you use to make it safe?
Here in our project that we actually work 100% out of our facilities, we first of all, before we start the project, we start running the same model that we use in the hostel in one floor, and this in the another floor we use this new model that we redesign. So we start to understand the quality of the exam if it was the same, because we take this like the same amount of patients, the same patients, actually like 100 patients, and pass through the first the traditional, the standard setup of equipment with the standard protocol that we use, and then we put it the same patients again the second floor with the new model, and we start to make case studies to compare what is the quality and the time that we are taking to understand if there was any kind of difference, and if it works, and if it works well, if it makes sense to use this kind of setup. And after that, we understand that we are not doing any kind of we don't put any kind of risk in the assistance. So every exam that we do, we don't need to, is not invasive. So we understand there is no risk of any kind of contamination or something like that. So everything we do, we like the most invasive part of our protocol is to put the eye drop that dilated the iris of the patient. So we understand we are not taking risk for the patients. So I think that's the main, but we understand that before we go to the expeditions with this new model, we made a lot of tests inside of the hostel to understand the quality and how is going to be the workflow of the new model that we were developing at the moment.
Thank you very much, Kyle. This is very important. And I also agree that identifying the scope of services for remote care provision is one of the key things that makes it safer. Be very careful with the type of services that you choose. Only provide those for which you can guarantee safety from the point of view of infection control, from the point of view of complications, and lots of other things, even potential resuscitation requirements, yeah, as a result of allergy or adverse event with medication, etc., etc. So be very careful with planning the type of services that you provide remotely, and then it makes the whole exercise much safer. Okay, Penina?
Yeah, so from my side, I will say that first of all, we conduct risk assessment first, yeah, to be able to determine exactly what kind of a patient are we dealing with, even from home. So and I'll take for example, like the chronic care program that I have just spoken about. What we do is that the patient will be able to take BPs from home or take sugars from home. And we have this nurse who is calling every day. We have 2 doctors that are working with this nurse separately, remotely. But now there's a call that is being made every day for a patient, and we are monitoring, the readings every day. Should we realize that there's a, deviation from normal, the doctors are able to tell at that point, is this a patient that we really need to continue seeing from home? Or do we need to have this patient to the hospital? Do we need to escalate care then from this level to the next level, say, for example, involve a cardiologist? So we are able to advise, we are able to pick patients from home. We know we do home visits as well. So at the end of every quarter, we are able to give patients their medical records, just meaning that we are able to monitor all through, and we can be able to tell by the end of quarter, is this a patient that we really need to continue seeing from home? So for me, it all starts with risk assessment first.
Thank you, Penina. Yes, that's also a great point. Risk assessment and also identification of early warning sign, and again, scoping, the list of conditions and the list of parameters, which may become critical, and then the patient setting it up so that every staff member knows it by heart. And then it becomes an alarming sign. Yes, the patient needs to be transferred to a proper healthcare facility environment. I agree with that. Okay, so unfortunately, we're running out of time, and it's been a very exciting discussion, I think. Thank you very much. We did not even take one of our questions about other projects of our speakers today. But we have our community of practice, and I kindly ask my colleagues who are joined on it's on Facebook, to share the link to our community of practice, where we plan to describe more cases, more improvement cases with results. And ideally, you will have an opportunity to discuss the projects with the teams that initiated the project. You will be able to ask your questions in the community of practice, so please join. The link is in the chat. And thank you very much for staying longer today. Thanks for being active, introducing yourself, asking questions. Hope to see you during our next webinars, and we'll announce the topics separately. Thank you very much. It's been great today. Thanks to all our wonderful panelists. Bye-bye.
Thank you.
Bye. Thank you.
Thank you.